Ladies and gentlemen, we are all different. But we all want to get old in a very healthy manner, but still we are very different. And when we get older, we are challenged by different diseases. You just heard we have a chance to get Alzheimer. There are many other diseases which we can get. And wouldn't it be nice that we not only know our risk, what we can get, but to definitely know at the moment that we develop something so that we could at that moment choose the proper treatment to prevent that? Well, that is something we would like to do and we want to achieve by working together in the Medical Delta, also just heard. But another problem is that even if you know that you develop a disease, in many cases drugs which we then get don't work. On the average, only 30% of the drugs we receive work, and in 70% of the cases they don't. And that is something I think we should not accept, and we therefore have to change healthcare and the way how we find these treatments and to find novel drugs. And that is actually what I want to talk today about, from how we can realize such a personalized medicine approach much better. Well, as you also just heard, the genes can predict very good whether we have a risk for a disease. Well, sometimes better than other cases, they predict whether we will get the disease, but for sure they don't predict at which moment a disease will develop. So what is happening at the moment? You go to a doctor if you have symptoms, if you don't feel well, you give a blood sample, some metabolite and other factors are measured, and by that you get a diagnosis, you get a drug, and you hope that it works. Therefore, I think that we need some better readouts to predict actually how the genome and the environment interact and result in which disease we develop and how that should be treated. And there, as mentioned before, I think that metabolites are very good as they're very reflective of the metabolism, and they are very nicely measuring the interaction of the genome with the environment and how the environment modulates the effect of genes on our further development. So rather than taking a blood sample at the moment that we are diseased, it would be, I think, much better to monitor the health state over our life course by just taking samples at many moments and to measure whether we are in the healthy state or whether we are at risk to lose our ability to cope with risk factors, with stress, with inflammation, with, for example, bacteria and so on, viruses. And at that moment that we need to support our resilience, that we change our lifestyle or take a drug so that we can get back to the healthy domain and stay as long as possible healthy. And for that, we should take metabolite profiles over our life course and to monitor by having our own reference set whether we get diseased, and if we get diseased and if we see changes in the metabolite profile, then to check in a database with ourselves as a reference point and many other data which treatment to take. And if you have good luck and there is a treatment, then we can be treated and we know what the outcome is. For that, we need high throughput metabolomics because it should be cheap. We also have to know which kind of biomarkers will predict the disease. And of course, we need the proper drugs to treat that disease. So I first want to focus on, are we able to measure metabolites in such a high throughput? Well, within the Netherlands Metabolomics Center, we have worked on several technologies how to realize high-throughput metabolomics, or at least to build the base to realize that. And one of the techniques which we have developed is electroextraction. You see it here. You put, for example, a blood sample or urine sample in such a multi-plate system. You put an organic solvent as a filter above it. You hang a droplet in it of water, and then you apply electric field so that the metabolites are moving from the sample through the organic layer into that droplet, in this case cations, and proteins and salts remain, because the problem is with mass spectrometer, you can't inject the whole blood sample into the mass spectrometer, but in this way, now you prepared the sample, and now you can directly infuse it and obtain a mass spectrum. And with this and other techniques which we have developed and we are developing at the moment, I think that the high throughput profiles will become available at a reasonable cost price of just a few euros or tens of euros. So, are we then there? Well, in many cases, maybe yes, but in some cases also not, because if we don't have a treatment yet. So what is then the route? Well, as Cornelia already explained, one route can be to study then not only metabolic profiles in blood, but try to translate that to in vitro systems to move and to study pathways at the cell and organ level. Using stem cell technology, it would be nice if we could make organs or tissues, which are organotypic properties, if we could make blood vessels, if we could make small cultures, neurovascular units which resemble the brain, or if we could build a small liver system and then do metabolomics and to see whether we can create the same kind of disease state, so that we then can use the data models to see what the disturbances of metabolisms are and what possible options are to treat. And if we find them, then we can translate that back to humans, apply that kind of intervention and treatments, and then see whether they work and to keep us healthy. So how can we create such in vitro systems? Well, there we developed a system based on phase guides, which were developed by Paul Fulto. Here you see the concept of the system. We have a microfluidic system, which is at the bottom of a microtiter plate, so it's robot compatible. And the microfluidic system is able to guide liquids in these glass chip. And what we can do there, we can pattern liquids. For example, we can pattern a gel into a lane, which is just separated by the small phase guide you see in between. And then one lane is filled with a gel, and then the lane next to it is being empty, so that you can then, for example, perfuse it with medium to grow the cells and to let them allow to differentiate further and to organize themselves into the proper tissue you want to study. Now you can also do it the other way around. You can have a gel and, for example, add liquid with endothelial cells, and then you can, for example, attach endothelial cells against the gel, just like in the body. Then you can create an endothelial or blood vessel against the matri gel or collagen, and then you can create blood vessels. So then we have created blood vessels like this, or we can stabilize them with parasites. So then you have parasite stabilized microvessels, and then we can start to investigate how these microvessels lose their integrity. For example, for the case that we want to start a kidney failure, because the microvessels or loss of the integrity of the blood vessels, microvessels, is the starting point of organ failure. And then we do metabolomics to see what kind of processes happens there at the cellular level. And then we can do that not only in one blood vessel, but in more. And we can then assess that with imaging analysis, like in this case, for example, we can perfuse the dextrin particles with VC, do imaging analysis to see whether we have a stable endothelial layer or not, whether we have a microvessel which is stable or which can be destabilized, for example, by perfusing blood from diabetes patients or from other patients. And then we can see how we can, for example, modulate that response of the endothelial cells to keep them stable and to keep our organs intact. And that's kind of assays we can not only do in one, but we can do it, for example, 96 experiments in parallel of one patient, or we can study 96 patients in the same experiment. So how can we then make now this personalized medicine possible? I think that the metabolite profiles are very well suited to study the differences between us. That we can study with metabolite profiles why certain patient reacts on a treatment and why not. But we can also translate these biomarkers, as mentioned, to our organ-on-a-chip systems or otherwise in vitro systems which are derived from patients, so that we can study the differences between patients also on the chip. And if we then do the same experiments, again measuring metabolites, we can take the data together. Then we are getting really big data because we have data from patient studies. We can use the cohorts and the longitudinal studies which are done, like the Rotterdam study. There are a lot of clinical studies. There's a line longevity study. So we can take all that samples, do the profiles, pick out certain patients, translate them to the organ-on-a-chip system to zoom into more detail, do the computational modeling, and then identify treatment options which we can then test in patients. And that is actually what you can only do if you work together in the medical delta between all the different people being here and that being the different university or clinical centers. And that's actually how we want to work together to make personalized medicine possible. And that is why we want to start the Metabolic Phenome Center now. And I want to invite you to join our effort how to change the healthcare. Ik heb gezegd.